Welcome back to Section 2 of the INTREC lecture on education, socioeconomic status, and health. I'm Maria Glymour, and we are at bullet number 2 in our overall lecture topics here about evidence on educational inequalities in health. This evidence is so extensive that, in fact, we're just going to give a few examples to show how broad these socioeconomic inequalities and educational inequalities, how persistent they are across outcomes. So what are some of the health outcomes that are patterned by SES? Cardiovascular diseases, some cancers, not all cancers, but many cancers, infectious diseases, not in all contexts, but in many contexts and many diseases. Unintentional and intentional injuries show socioeconomic patterns. Mental health, a whole range of mental health outcomes, including very common mental health disorders such as depression. And disability and quality of life outcomes show pretty consistent patterns by socioeconomic status. And these patterns, it's not just any pattern, it's a pattern particularly that people with high socioeconomic status have better health and people with low socioeconomic status have worse health. So that's the particular pattern. Just to give you a few examples, these are data from the United States, and these are data showing for men and women mortality rates. So here are men, here are women, and these are cause-specific mortality rates. I want to note that this is on a long scale. It's deaths per 100,000 population. And what you can see is that in the dark blue here, which is men with less than 12 years of education, you can see the death rate per 100,000 around 500. Men with 12 years of education, it's a little bit lower. And men with 13 or more years of education, it's quite a bit lower. Now, remember, this is on a log scale, so this difference is actually quite large. And these are for mortality related to chronic diseases. So you see this very clear gradient. And in this population, the 12 years of education is around the median education. So that's roughly speaking, a third of the population are in each of these categories, and you see this very clear trend. How about for injuries? For injuries, you see essentially the same pattern, if not more striking, where people with less than 12 years of education have much higher injury-related mortality than people with men with 12 years of education, and they have higher mortality than men with 13 or more years of education. The same pattern prevails for communicable diseases we see over here, where men with the most education have the lowest mortality rates due to communicable diseases. Now, when we look at women overall, we see very similar patterns where there's a very clear educational gradient in mortality from chronic diseases among women, for injuries among U.S. women, and for communicable diseases among U.S. women. So very consistent across all causes of death. Here's another example from the INTERHEART study. INTERHEART is essentially a case control study conducted in around over 50 countries across the world. And they focused on acute myocardial infarction. And they focused on, in particular, education and the social pattern by education and odds of acute myocardial infarction. And I want to draw your attention to the figure here. And what you see, it's separated into high-income countries and low- and middle-income countries. And each of these is showing an odds ratio. Here's the odds ratio on the y-axis. Each of these is showing an odds ratio, and the odds ratio is relative to the highest education group in the low- and middle-income countries or the high-income countries. So that's the reference group with an odds ratio of 1 is the reference category. So in high-income countries, essentially the lowest education group, which are people with less than or equal to 8 years of schooling, have 61% higher odds of acute MI compared to people in the highest education group in the high-income countries, who are people with college or more educated, so at least some college or more. So you can see this very strong gradient in acute myocardial infarction across a very large set of high-income countries. How about in the low and middle-income countries? What we see there is that there's also a very consistent, strong gradient. The relative effect is slightly smaller, so that contrasting the lowest education category to the highest education category, we see a 25% elevation in odds of acute MI in for individuals living in low and middle income countries. So in both groups of countries, there's a very clear social gradient and very consistent. However, it seems to be in relative terms a little bit larger in low and high income countries. It should be noted that stop there. Okay. There are many other health examples that we won't go through specifically. For example, common mental disorders have been shown to be socially graded in many, many countries, and that seems to be a little bit more consistent across education of the many measures of socioeconomic status that people have examined. The association with education seems to be a little bit more consistent than association with other factors. Smoking, tobacco use, this varies a little bit by country, and it varies by when in the development of the smoking epidemic you actually examine it, but there eventually an education gradient emerges. Non-fatal injuries, again, this differs a little bit by socioeconomic status, but in a very wide range of situations, non-fatal injuries have been shown to be socially patterned. In fact, the association between socioeconomic status and health is so persistent and so widespread, it's almost easier to ask what things are not patterned by socioeconomic status. Are there any examples we can think of in which something isn't patterned, in which people with more education would have worse outcomes? So at this point, I'm going to pause and suggest that you stop and think about are there any outcomes that you can think of in which you do not expect a socioeconomic gradient, and what are those outcomes? What are the circumstances under which you might not see a social pattern? So I'll stop here for a couple minutes. I forgot to restart my clock. What are we doing?
It's 7 minutes now.
Okay, so that's great. Okay, welcome back. We'll come back. So when is a socioeconomic pattern not going to emerge? For one thing, if there's no knowledge about how to prevent a disease, then education and money may not be useful to help you prevent the disease. So if we really don't understand the etiology of disease, it may not matter that you have high education because there's nothing to be learned about how to prevent the disease. In some cases, diseases are caused by behaviors or treatments that are considered high status and are therefore overused by high SES individuals. And smoking is an example where there is a time period where the social class gradient in smoking reversed as we came to understand how aversive it was, how toxic it was. Essentially, theory suggests that new knowledge about how to prevent or treat a disease is used first by people with high education and only later by people with low education. So as our understanding of disease and disease prevention emerges for any particular condition, a socioeconomic gradient is established such that high education people with money and resources are able to take advantage of that knowledge and protect themselves, whereas low education people and people with no money and no resources are much slower to be able to use that information to protect themselves. So we will stop there for section 2.